In this episode of Crit Care Bites, I'll be discussing about acute kidney injury and renal replacement therapy in the ICU. The topics that will be discussed include acute kidney injury and what it entails, the different mechanisms of fluid and solute removal, the differences between intermittent and continuous renal replacement therapy, indication and timing considerations, how dosing is decided, concepts of pre and post filter fluid replacement, vascular access, anticoagulation, specifically looking at regional citrate anticoagulation, some basics about pressure alarms, how do we decide on discontinuation of treatment, and a discussion about some special populations including acute brain injury, hyponatremia, and liver failure. Acute kidney injury is a common and important problem in the ICU and represents the commonest cause for renal replacement therapy. It is associated with a high incidence in critically ill patients and is also associated with high mortality rates of up to 60%. Importantly, this problem extends beyond the ICU because in terms of the 1-year renal recovery, this is incomplete in about 1/3 of patients, and up to 19% of patients actually remain renal replacement therapy dependent even after they leave the ICU. So this is the 2012 KDIGO definition and classification of AKI, and this is based on the creatinine level as well as urine output parameters that are summarized in this table. So causes of AKI in the ICU are oftentimes multifactorial, and they can be evaluated based on a pre-renal, renal, and post-renal classification. Oftentimes, pre-renal causes in the ICU include that of patients with different types of shock, conditions like cardiorenal and hepatorenal syndrome, as well as abdominal compartment syndrome can be seen in specific clinical contexts. There are multiple causes of renal causes of AKI, and in the ICU specifically, patients are on many medications and are subjected to many contrasted scans. So these are important considerations. And in specific instances, conditions like rhabdomyolysis, tumor lysis, and even venous congestion, especially in the context of fluid administration, should be considered. And also importantly, post-renal causes should also be evaluated for. So next we'll move on to the different mechanisms of fluid and solute removal. So in terms of fluid removal, this is achieved through a process called ultrafiltration, where plasma water is forced through across a semi-permeable membrane by hydrostatic pressure, and in the process, water is removed. In terms of solute removal, there are two main mechanisms, namely convection and diffusion, corresponding to the two means of renal replacement therapy strategies of hemofiltration and hemodialysis, respectively. So for convection, the way this works is that transmembrane pressure drives plasma water across a semi-permeable membrane as described in ultrafiltration, and this process actually drags solutes alongside the plasma. Hemofiltration tends to remove middle-sized or slightly larger molecules compared to hemodialysis. And in order to actually achieve significant solute removal through convection, high ultrafiltration rates are required. As such, in conventional or intermittent hemodialysis, where we still actually do some degree of ultrafiltration to remove fluid, the actual solute removal that is accrued from this process is actually very minimal. In terms of diffusion or hemodialysis, solute removal takes place across a membrane, and it's driven by a concentration gradient of solute between the blood on one side of the membrane and the dialysate on the other side of the membrane. And this concentration gradient is maintained by a countercurrent flow mechanism. So smaller molecules tend to be removed through diffusion. So in the next couple of slides, we'll discuss the differences and the considerations between intermittent and continuous renal replacement therapy. So in terms of intermittent options, we have intermittent hemodialysis or just isolated ultrafiltration or ISO-UF. In terms of continuous methods, we have different permutations and combinations of hemofiltration and hemodialysis. So you can have standalone hemofiltration in CVVH and standalone hemodialysis in CVVHD, and these two can be combined to produce a continuous veno-venous hemodiafiltration, where arguably the merits of both dialysis and hemofiltration can be achieved. Peritoneal dialysis is actually a means of continuous renal replacement therapy, but we will not be talking about it in this discussion. And in the middle, we have options like sustained low efficiency dialysis that basically is performed intermittently but at a slower rate, and hence may be able to achieve the benefits of both spectrums of renal replacement therapy. So this is a schema of the CRRT circuit. The key components include double lumen veno-venous catheter, an extracorporeal circuit, hemofilter, blood pump, and effluent pump. In hemofiltration or ultrafiltration, solutes and plasma water is forced across a semi-permeable membrane by high UF rates with simultaneous infusion of replacement fluid with replacement pump. And this can be given either pre-filter here or post-filter as seen here. In terms of hemodialysis, solutes and plasma is moved across the semi-permeable membrane into the dialysate compartment of the hemofilter. So the dialysate is here and it's moved across, and blood flow is in the opposite direction of the dialysate flow. So this table summarizes the pros and cons of intermittent versus continuous renal replacement therapy modalities. And importantly, the decision or choice of the mode of renal replacement therapy has to be individualized to the patient. So intermittent dialysis allows for flexible timings for downtime, and this facilitates procedures, scans, even physical therapy. In terms of the fluid removal and solid removal, this is actually done very quickly and efficiently. And given the shorter duration of exposure to a circuit, the exposure to anticoagulation is less if it is used, and overall it is cheaper. The main postulated drawbacks are that of hemodynamic instability, as well as increased rates of solute shifts, resulting in a potential phenomenon of dialysis disequilibrium, which will be discussed later. And the benefits and disadvantages of continuous renal replacement therapy are essentially the opposite of what's been mentioned. So the main advantage is really hemodynamic stability and allowing more predictable volume and solute control. In terms of the drawbacks wise, it is more costly. There's higher potential for filter clotting over time, and it also risks other problems like hypothermia and problems associated with the types of anticoagulation modalities that are used. transportation out of the unit or even disruptions for important procedures can be done to some extent. Recirculation on CRRT is possible for a time-limited duration, usually for up to about 2 hours. However, beyond that, then the circuit would have to be interrupted, potentially resulting in wastage. So, from an evidence-based point of view, while continuous modalities have oftentimes become the mainstay for critically ill patients in many ICUs, there is actually little clear literature benefit of CRRT over intermittent dialysis. So on the left side, we see a landmark RCT that was performed in 2006 that actually didn't show any survival difference between CRRT or intermittent hemodialysis, and a Cochrane systematic review and meta-analysis performed in 2007 actually likewise didn't show any similar mortality benefit. Of note, however, CRT was associated with higher mean arterial pressures and higher risk of filter clotting. In terms of the guideline recommendations, the 2012 KDIGO guidelines actually suggests CRRT to be used in patients with acute brain injury or in patients with hemodynamic instability. This slide describes briefly some of the common settings we use in the prescription of intermittent dialysis. For intermittent hemodialysis, we usually set blood flow rates between about 200 to 250 mils per minute, and dialysate flow rate is usually set about 500 mils per minute. And typically, it's conducted over a duration of about 4 hours. For slow, low efficient dialysis, blood flow rate is usually set at about 150 mils per minute, and the dialysate rate is at about 300 mils per minute, and duration ranges anywhere between 6 to 8 hours. So, dialysis disequilibrium is something that tends to occur more with intermittent rather than continuous renal replacement therapy. It occurs because of rapid osmotic shifts between blood and brain compartments and can result in cerebral edema, raised intracranial pressures, and neurological complications. So they tend to occur during dialysis initiation, especially in patients with very high levels of urea or hypernatremia. And the risk is usually reduced by either starting with SLAD instead of intermittent hemodialysis, using shorter initial dialysis durations, using smaller surface area dialyzers, and actually limiting the urea reduction ratio to less than 40%. So I think in summary, deciding between continuous or intermittent renal replacement therapy will really have to consider why renal replacement therapy is needed in a critically ill patient, and the different factors of pros and cons will have to be weighed and considered in making this decision. In terms of the indication and timing for renal replacement therapy, this will be discussed in the next couple of slides. So the traditional classic emergent indications, I think we're all familiar, and these include solute disturbances like metabolic acidosis and hyperkalemia that's refractory to medical therapy, diuretic resistant volume overload, and certain drug intoxications that are amenable to clearance by renal replacement therapy. Other indications would include metabolic derangements in contexts like tumor lysis, rhabdomyolysis, or even other severe electrolyte problems like hypercalcemia, hyperphosphatemia, would be other considerations for renal replacement therapy. So the next question that arises is about the timing of renal replacement therapy initiation.
in the absence of any of the heart indications that were described in the previous slide. So there were 5 landmark studies, namely the Elaine, AKI, Ideal ICU, START AKI, and AKI 2 studies that helped to answer this question. So the first study was Elaine in 2016 that showed a potential benefit for early renal replacement therapy. However, this was performed in a predominantly surgical population, was a single center, fairly small study. And when this question was re-examined in 3 larger studies, namely the KIKI, Ideal ICU, and START AKI trial, the findings were actually neutral, suggesting that there was no need to rush in immediately in a patient with severe category 3 AKI, and some waiting was reasonable because actually some of these studies showed um, that there was an overall reduction in renal replacement therapy related complications like line infections, for example, in patients who actually waited. And in terms of overall mortality, there wasn't any difference. The Akiki 2 study really aimed to look at what is a reasonable time frame for waiting, and looking at how it was conducted. It was essentially studying sort of a delayed versus a ultra delayed kind of strategy. And it was suggested that in patients with category 3 AKI, waiting too long, for example, beyond 72 hours, or if we waited until the urea level was extremely high at more than 50, there was suggestion of harm. Hence, the thinking at this point in time would be that perhaps some degree of waiting is reasonable, but not indefinitely, especially if there is no suggestion of renal recovery in the context of a severe acute kidney injury. So this is just a summary of some of the discussed studies that were previously mentioned. So I think a practical approach is that the evidence tells us that there is, in general, no rush for early initiation, and it is probably harmful to wait too long. However, bearing in mind the limitations of these aggregated data, decisions for renal replacement therapy initiation has to be individualized to the patient, taking into account the underlying disease, the expected trajectory, and also practical considerations like uh, access to equipment, expertise for line insertions at various times of the day, etc. So I think the trajectory piece is also very important. So in patients who may not have uh, met heart indications, but are, for example, in the midst of developing severe septic shock, and it is only expected that things will get better perhaps a couple of days, these patients may benefit from earlier renal replacement therapy initiation. And some adjuncts that has been described in the literature to help to stratify perhaps borderline patients would include the furosemide stress test, where an IV furosemide dose of uh, um, 1 to 1.5 milligrams per kg is administered, and the urine output of more than 200 mils within 2 hours is suggestive of some degree of intact renal function. And other things like renal biomarkers and scoring systems have also been described, but are probably more relevant in the realm of research.
So next we'll discuss about dosing of renal replacement therapy with a focus on continuous renal replacement therapy. So conceptually, um, dosing of renal replacement therapy is described as volume of blood purified measured in terms of a clearance rate of a representative marker solute. Typically, this concept of KT over V is used in patients with CKD, but in critically ill patients, this approach is not feasible because of wide variations of urea and volume in ICU patients. So using CRRT, your dose is essentially the total effluent rate measured in terms of mils per kg per hour, and it takes into account the dialytic component, the hemofiltration component that is measured in terms of replacement fluid, as well as the net ultrafiltration. So this can be seen here in this renal replacement therapy prescription that is shown on the screen. So if you see the components that are described, we have the dialytic component that corresponds to the dialysis aspect of the CVV-HDF, the replacement fluid that is the hemofiltration component, as well as the fluid removal. So summatively, if you look at this, the total effluent rate is 2.7 liters per hour. And if we divide this by the patient's weight of 71 kg, this gives us um, uh, a dose of 38 mils per kg per hour. So that is how renal replacement therapy dose is computed. In terms of optimal dosing, while early studies actually showed potential benefit for high-dose CRRT, this was actually refuted in more recent studies. So the 2012 KDIGO guidelines suggested a dose of 20 to 25 mils per kg per hour. And this is basically one out of the two landmark studies, the ATN and the renal studies, that suggested that a lower dose of 20 to 25 compared to a higher dose was equivalent, and there was actually suggestion of higher complications with too high a dose of renal replacement therapy. However, when it comes to the actual prescription, we tend to prescribe a slightly higher dose of 25 to 30 mils per kg per hour because the actual delivered dose is usually a little bit less in view of vascular factors like recirculation, hemofilter factors like clogging or clotting, and prescription factors like whether you give your replacement fluid pre or post filter. Um, so So in the next couple of slides, we'll be explaining the concept of a pre and post filter fluid replacement in the context of hemofiltration. So if we prescribe CVV-HF or CVV-HDF, this is something important that we need to consider. So this is the schema that we went through earlier, and just to refresh, if there is a hemofiltration component to the prescription, then replacement fluid can be given before the filter here or after the filter here. So why does it matter? Um, it matters because there are certain pros and cons with each approach. So when the fluid is given pre-filter, this has the advantage of actually prolonging the filter life because if you think about it, the blood that flows through the filter is more diluted, and hence the risk for clotting is actually lowered. Um, the drawback of this, however, is that the solid removal is actually less efficient because of the fact that the blood is more dilute by the time it reaches the filter. And on the flip side, if it is given a post filter, It actually increases the overall efficiency of dialysis, of renal replacement therapy rather, but there is an overall reduction in the filter life, and there is an important concept of a filtration fraction that which we'll discuss in the subsequent slide. So filtration fraction is essentially the percentage of plasma that is being removed from blood during ultrafiltration, and it's essentially the ratio of the filtration rate to the plasma flow rate. So numerically, this is basically the total UF, which will be your pre-filter, post-filter, and your net UF added together, divided by the blood flow rate times 1 minus hematocrit, plus a pre-filter replacement flow rate. So as we can see, when we give the replacement fluid pre-filter, the denominator is bigger and the filtration fraction is actually lower, right? So we will actually want to aim a filtration fraction of less than 20 to 25%, as higher levels are actually associated with higher risk of filter clotting. So another concept is that of a dilution factor. So dilution factor is something that needs to be considered when pre-filter fluid is administered. And as described earlier, the blood gets diluted before reaching the filter, and it reduces the overall effectiveness of solute clearance. So mathematically, the computation is blood flow rate times 1 minus hematocrit divided by a denominator of blood flow times 1 minus hematocrit plus the pre-filter replacement rate. And if you think about it, the effective delivered dose of renal replacement therapy is essentially the dilution factor multiplied by the prescribed effluent dose, which is your RRT dose, times the actual number of hours of renal replacement therapy, taking into account downtimes of the machine. So next, about vascular access. I think it's important to highlight that vascular access is one of the most, or if not the most important, determining factor for effective renal replacement therapy, as it allows for adequate flow rates and prevents filter clotting. So if you look at the 2012 KDIGO guidelines, the recommended order of preference is right IJ, followed by femoral, followed by the left IJ, and lastly the subclavian. And this is due to the flow dynamics that are associated with each of these different access sites. And importantly, apart from the site, is the appropriate catheter size and lengths as described here. So the right IJ ideally should be about 16 cm, left IJ about 20, right femoral 24, and left femoral also 24 centimeters, in order to be able to be sited at a location that allows good flow rates. Of course, patient habitus also will have to be considered, and eventual confirmation on chest X-ray for the IJ catheters would be necessary. So good vascular access, as mentioned, plays an important role in preventing circuit clotting, and also practical considerations are important. For example, if patients are going to be prone, then the femoral is least preferred. And actually studies have shown that infection rates are actually fairly similar across IJ and femoral sites, except in obese patients. And generally, the left IJ site is avoided if possible, because studies have shown greater rates of catheter dysfunction and inferior flows compared to the femoral and the right IJ. So in the next couple of slides, we'll be discussing about anticoagulation for CRRT, and specifically focusing on regional citrate anticoagulation. So why is anticoagulation required? It's mainly required basically to prevent clotting of the filter in order to achieve adequate renal replacement therapy, and to prevent loss of filter life. However, this has to be balanced against bleeding risk. And importantly, besides anticoagulation, other important measures to reduce the risk of clotting include having good vascular access, ensuring that the filtration fraction is less than 20 to 25%, and using strategies like a pre-filter fluid replacement. So in terms of anticoagulation options, broadly speaking, can be classified into systemic or regional approaches, and regional is generally preferred because the anticoagulation effect is constrained to the extracorporeal circuit. And the two most commonly used anticoagulants are that of heparin as well as citrate, where citrate actually has become increasingly the preferred modality because of studies demonstrating the superiority in maintaining filter life. It also has certain advantages such as lower bleeding risk, avoidance of complications that can be associated with heparin, like heparin-induced thrombocytopenia. However, um, it is important that when citrate is used, patients need to be closely monitored for potential complications, which will be discussed later on, and strict protocols need to be set in place. So the way that regional citrate anticoagulation works is that citrate chelates calcium, and calcium is an important cofactor for the coagulation cascade. It is involved in the generation of thrombin and activation of factors 2, 9, and 10. So citrate is essentially infused before the filter within the circuit, and within the circuit itself, there is anticoagulation effect because there is no calcium action in order to activate and maintain the coagulation cascade. Um, Thereafter, calcium is actually infused systemically back to the patient so that there is systemic normal calcemia, and the anticoagulation effect is hence lost because you have normal calcium levels in the rest of the circulation. So what happens with these calcium citrate complexes? They are removed both by the circuit as well as by the body itself, mainly by the liver and partially by the muscles. So other important electrolytes like magnesium also can get chelated away, hence it's important to check them regularly. So these two diagrams basically show how a regional citrate anticoagulation circuit is set up. So starting with citrate replacement fluid, this is typically administered uh, pre-filter, and nowadays we have developed replacement fluids that contain citrate. So fluids like Rejosit are actually citrate containing fluids, and this is administered pre-filter. So between the infusion point and the calcium infusion point post-circuit, anticoagulation is achieved because of therapeutic hypocalcemia. And this is actually monitored by checking calcium at a sampling port just distal to the circuit. So we ensure that the calcium levels are low within the system. And importantly, systemic calcium is sampled to check that the systemic calcium is normal. So this can be done either through an IA line or a CVC. And it's important to prevent complications of hypocalcemia. So of note, when there is a concomitant dialysis component when we use citrate, then the dialysate that is used has to be calcium free. So solutions like Bifossil are actually calcium free and can be used in this context. So these are some important numbers to bear in mind. So firstly, we talk about citrate dose. So an important concept to actually highlight is that citrate dose is actually affected by both the blood flow rate as well as the citrate flow rate that is being delivered. With these two being coupled, as we can see on the table on the right hand side here, um, So for example, with a blood flow rate of 100 mils per minute, we need a citrate flow rate of 1000 to achieve a citrate dose of 3.0 millimoles per liter. So this comes in later when we talk about different strategies to address problems like citrate accumulation. But the take-home message here is that there's a concept of citrate dose, and this is a factor of both blood flow and the delivered citrate amount. Secondly, as we already mentioned, we want a post-filter ionized calcium to be low, and this usually less than 0.4 would be suggestive that there is adequate anticoagulation of the circuit. But within the systemic circulation, we want systemic normal calcemia, and we want an ionized calcium level of 1 to 1.2. And hence, protocols are built to ensure that appropriate calcium replacement is administered to maintain these levels. So next we talk about this problem of citrate accumulation, sometimes termed citrate toxicity. So I think at the outset it's important to clarify two different situations, that of citrate accumulation and citrate overload. So citrate accumulation, what is usually equated to toxicity is a situation where citrate calcium complexes are actually not adequately metabolized because the body's metabolizing capacity is overwhelmed, and this results in a metabolic acidosis and systemic hypocalcemia, where there is reduced ionized calcium systemically, and this is a life-threatening condition. On the flip side, there is a separate situation called citrate overload, where there is excess of citrate administration. So this is usually when your citrate flow rate is high, but it is in the context of an intact metabolism where actually the citrate calcium complex can be processed and metabolized away, and this actually results in a metabolic alkalosis because you can either explain it away through the fact that when citrate is metabolized, it dissociates into bicarbonate, or through the strong ion difference through trisodium citrate that is resulting in an increased strong ion difference. But regardless, the clinical presentation is that of a metabolic alkalosis, and there is actually no systemic hypocalcemia. So this problem is actually not a life-threatening problem as compared to citrate accumulation. So how do we diagnose citrate accumulation? We see a worsening high NR gap metabolic acidosis. There is an increase in the total to ionized calcium ratio. And this is explained in this diagram here because, as you can see, the total calcium levels actually doesn't go down because you still have calcium citrate complexes. However, the ionized calcium is now significantly less because of the fact that they are all bound away by citrate. And you also have systemic hypocalcemia with an increasing need of calcium replacement to maintain your systemic calcium levels. So why does citrate accumulation occur, and what are some risk factors? So if we think about it, as we mentioned, apart from being cleared away by the renal replacement therapy circuit, the body actually plays an important role, specifically organs like the liver, in terms of metabolizing citrate. So for the liver to be able to metabolize citrate, firstly, we need adequate oxygen delivery to ensure that the liver cells and the mitochondrial functions within the liver are intact. So in patients who in severe shock or with hepatic dysfunction, then that can be impaired, and citrate metabolism or the capacity to metabolize citrate is compromised. Other situations to be very cautious about the use of citrate would be in patients with hypocalcemia, because as mentioned, essentially citrate chelates away calcium. So in conditions like rhabdomyolysis, tumor lysis, where the calcium levels are already very low, it would be very risky and dangerous to actually do regional citrate anticoagulation. And as mentioned, liver failure, severe shock, or in conditions where there's suggestion of mitochondrial dysfunction, or even severe coagulopathy, there should be caution exercised with citrate use. And finally, how do we manage this problem? So there are a few strategies. So firstly, we can reduce the overall citrate dose, but the dose of citrate is essentially what determines adequate anticoagulation. So if we reduce the dose, then we may have suboptimal anticoagulation, and this may result in filter clotting. Other things that we can do would be to reduce the blood flow rate. So as we recall, the citrate dose is actually coupled to blood flow rate and the delivered citrate flow. So if we actually reduce the blood flow rate, the amount of citrate that needs to be administered is actually less, and there's an overall less citrate load that the patient has to metabolize. Alternatively, increasing the dialysis component is actually a useful strategy because, as also previously mentioned, up to about 60% of citrate is actually cleared away by the circuit. So if we increase the dialysis dose, or if appropriate, the filtration dose, then some of the calcium citrate complexes can be cleared away. Alternatively, a different type of anticoagulation or no anticoagulation can be considered. So next, we'll be briefly talking about pressure alarms in the CRRT machine. And these are important to recognize because there are different situations that may arise causing different types of alarms. So I think going through the circuit, there are a few important alarms. There's the excess pressure, there's the filter pressure, and then there are two important concepts of filter pressure drop and transmembrane pressure, and then there's also the return pressure. As we can see, at the excess side, the pressure is negative, and subsequently, beyond the pump, the pressures downstream are actually positive. So these are basically the ranges of what are roughly normal pressures. And this slide summarizes some of the important causes of different pressure alarms. So for the excess, usually the problem that we may see are extremely negative pressures, and this can be due to patients who are very hypovolemic if the catheter is actually against a vessel wall and sucking against the vessel wall, or perhaps in patients taking very, very deep breaths and resulting in blood being pulled from the opposite direction of the catheter flow. And sometimes it could be due to positional reasons. In terms of the filter pressure, it can become very positive as the filter gradually clogs up, or if it clots, or sometimes if there's a problem in terms of the line being kinked or clamped. We'll talk about transmembrane pressure in the subsequent slide. And finally, for the return pressure, the situation that is often encountered is a very positive return pressure, and this can occur if there's any clotting, any kinking or dislodgement. And negative pressures are usually less common. It could be due to a line disconnection or just very low blood pump speeds, but usually this is much less common. And just two concepts to highlight. First, that of transmembrane pressure. Second, that of a pressure filter drop. A transmembrane pressure tends to be elevated when there is clogging of the pores of the membrane. So this tends to occur when there is significant amounts of hemofiltration. So essentially the transmembrane pressure is the pressure difference between the blood side and the dialysate or ultrafiltrate side of the membrane. So if you can imagine, if you are doing a lot of ultrafiltration, then the pores will clog up, and this results in a high transmembrane pressure. Conversely, when the pressure filter drop is high, more than 26 millimeters mercury, this suggests clotting, and the management strategies would then be to increase anticoagulation or to assess the excess to see whether that can be further optimized. So now in terms of discontinuation of renal replacement therapy, we'll be going through the considerations. So compared to initiation, I think studies looking at discontinuation, there's much fewer studies, and largely it is based on clinical discretion, or looking at whether the initial acute insult has resolved, how the urine output is, what's the trajectory of urea creatinine, solute stability, fluid balance, and there's also ongoing research looking at biomarkers. So these different studies highlight that urine output is an important prognostic factor of being able to come off renal replacement therapy. And oftentimes, practically, what happens is that the solute and fluid status is monitored between episodes of renal replacement therapy. And sometimes this time window is stretched, and patients are monitored and sometimes gradually weaned off. So we'll end off with just looking at a few special populations that will require special attention. So the first is patients with acute brain injury. So the important considerations is that uh, decreases in blood pressures or fluctuations in blood pressures may cause changes in the cerebral blood flow. Secondly, regarding concern of disequilibrium, changes in solutes also will affect the movement of water in and out of the brain. It can worsen cerebral edema, and bleeding risk, especially if anticoagulation is used, is important in the context of intracerebral hemorrhage. So generally, CRRT is favored uh, over intermittent hemodialysis in patients with severe brain injury. However, if intermittent hemodialysis is used, then SLAD can be used instead, and perhaps lower temperatures to maintain hemodynamic stability can also be considered. Caution should be exercised to minimize excessive fluid and osmotic shifts, and anticoagulation, especially if systemic, should be avoided if possible. Secondly, in patients with problems with sodium, be it too high or too low, will need special attention. So specifically for hyponatremia, we normally, especially in chronic hyponatremia, would only want patients to have a rise of about 6 to 8 millimoles over 24 hours. And the important concept is to bear in mind that the concept of either dialysis or hemofiltration is that the end result of the solutes will oftentimes be in accordance to what is either replaced or dialyzed against. So given that the levels of sodium concentration are usually that of near normal physiological levels in patients with hyponatremia, if we dialyze them against these pre-made fluids, the rise will be too much, and there will be risk for osmotic demyelination. And likewise, if there's hyponatremia and they are dialyzed against that sodium bath, then there will be risk for potential cerebral edema if the sodium falls too quickly. Hence, there may be a need for manipulation of these bags of fluids using D5, or perhaps running a separate D5 infusion. And different hospitals have different protocols to mitigate this issue. And finally, looking at patients with liver failure, the considerations would include that of actually cerebral edema, similar to the acute brain injury population, hyponatremia, sodium dysregulation, and coagulopathy. I think importantly is that while citrate has oftentimes been described to be avoided in liver impairment, actually there have been studies that show that it can be considered to be used carefully with close monitoring. Hence, it is in a sense not a strict contraindication, but close monitoring and judicious caution will have to be exercised. So, moving on to the final summary slide. Uh, so when do we initiate renal replacement therapy? So firstly, if there are severe solute or fluid imbalances refractory to medical therapy, if there are severe AKI without these, then we would consider to initiate within 72 hours, but also taking into account the trajectory of the patient and initiate earlier if, let's say, there are concerns. Intermittent versus continuous, well, there is no strong evidence that one is superior to the other. Generally, if there's hemodynamic instability or significant acute brain injury, then perhaps continuous renal replacement therapy should be considered. However, there are practical pros and cons to be considered between the two options. In terms of dosing, the general recommendation of 20 to 25 pills per kg per hour is suggested, but in terms of practical prescription, a slightly higher dose, taking into account inefficiencies, should be considered, and higher dosing may be considered in severe solute derangements, toxins. And in terms of pre versus post filter fluid replacement, in the context of hemofiltration, pre-filter is beneficial for filter preservation, but the trade-off is that of less effective solute clearance, and vice versa with post-filter. So practically speaking, I think what wasn't mentioned earlier was that when we use solutions like Regosit in the context of citrate anticoagulation, then the pre-filter fluid volume is actually predetermined based on the citrate dose and the blood flow rate. And then the balance can be split post-filter or dialysate. And in terms of vascular access, the preferred sites would be right IJ over femoral over left IJ, and also important to ensure that the appropriate size of the catheter is used. RCA has supplanted heparin as the preferred modality if there are no contraindications because of superior filter life preservation. And when it comes to concerns of citrate accumulation, this can be diagnosed based on worsening high ion gap metabolic acidosis, increasing total to ionized calcium ratios, as well as worsening hypocalcemia, especially in the context of patients with liver impairment or severe shock. Management would include that of reducing the blood flow rates, increasing dialysis dose, reducing the citrate dose, or withholding or using an alternative anticoagulation. And finally, when it comes to discontinuation of renal replacement therapy, this is largely clinically guided based on resolution of the initial insult, improvement in urine output, as well as solute and volume stability over time. So this is the last slide, and thank you very much.